Hi, everybody. Welcome. We'll get started in just a couple of minutes. Thanks for joining today. Great. Well, let's make a start. It's 1 o'clock. Thanks for being here. Welcome to this Training Hub webinar, another one in our Women's Health series. So my name's Sam, Dr. Sam Morgan. I'm a Bristol GP and a menopause specialist. And this session today, we're going to be thinking about clinical presentations in women's health. We've got an hour or so together, so I can't go into a deep dive into anything particular, but hopefully it's going to get you thinking, get you sort of reflecting on areas that you're more confident in and perhaps areas where you're less confident. So it might be a springboard to other things that you might want to look at. It'd be lovely to know who's here today. So if you're happy to perhaps just say hi in the chat, let me know your role particularly. Often with these webinars, we have loads of different people, which is really great. But just to help me know who you are, that would be brilliant. So some of you may have joined the consultation skills session that we ran. And in that session, we talked about the gender health gap and the need for us to think about consulting differently with women. This is one of the only slides that was also in that session, and it shows an image from the Women's Health Strategy, which was published in 2022. And it's essentially the government's 10-year plan about actions to take to try and improve the health and well-being of women and girls in England. And it talks about women's health needs and general health needs, and thinks about 5 key themes. So menstrual health, contraception, menopause, female cancers, and long-term conditions. And so this is the framework that I've used to think about today's session. So it's hopefully going to be a session that will help you, as I said earlier, think about other things you might want to explore. Now, we've done lots of sessions over the past couple of years around women's health. We've got sessions on contraception, menopause, PMDD, endometriosis, menstrual health, cardiology. They're all linked through from the Training Hub. So do please have a look at some of those today if that would be helpful to do a bit of a deeper dive into one of those areas particularly. And although I'll be referring to women today, I of course want to acknowledge that not all women were assigned female at birth, and that some trans men and non-binary people can also be affected by things in our topic today. Great, so I can see some comments in the chat, thank you. So yeah, lovely, great. So we've got some GPs, some ANPs, some pharmacists, fantastic. Women's health lead nurse, great. Oh, sorry if you can't hear Jessica. Yes, please do retry. Hopefully it'll work if you rejoin. Super. So these are the areas that I'm going to look at. Please feel free to post things in the chat as we go. reflections, comments, questions. I'd love it to be as interactive as you'd like it to be. But yeah, really interested to hear your thoughts about these different areas as we go through. So we're going to have a look at menstrual health, have a think about contraception and fertility, menopause, pelvic health, female cancers, especially some of those less well-known ones, and some of the long-term conditions. You'll get a recording of the webinar today, and I've also done a resource sheet with lots of the key links that will be shared in the presentation today. So that'll be sent out to you afterwards as well. So firstly, thinking about menstrual health. So periods are so variable. There's a huge variation in what people experience. But menstrual health can have a real impact on physical health and on mental health. And if we're going to be able to recognise PMS, endometriosis, PCOS, heavy menstrual bleeding, we've got to have a really good feel as to what normal looks like. Normal in terms of a period and normal in terms of a cycle. And you may be somebody who has periods themselves. We only know about our own cycle, so it's quite difficult, isn't it, to know if what you experience is considered to be normal and is similar to somebody else's experience. You may be somebody who doesn't have periods, and so this could be completely foreign and alien. And a normal period is considered to be 2 to 7 days, every 24 to 38 days, and one that doesn't impact significantly on life. And in our recent menstrual health webinar, this really was the key, was thinking about what's the impact potentially of that period, of that cycle on somebody's life. And if it is impacting, if it's stopping attendance at school or at work, if it's impacting on somebody's ability to be enjoying life, then that's not normal. And we need to support that person with having that taken seriously and thinking about how to support them in managing that. And this campaign from Wellbeing of Women, Just a Period, centralises around that whole concept, looking to stop normalising pain, flooding, things that can really, really impact people as being just a period, and time to take it seriously, recognising the impact that it can have. So recognising our normal helps us then to think about what we wouldn't consider as being normal. I like very simple ways of thinking about things. So for me, if I'm thinking about periods, I'm thinking, well, is there too much bleeding or too little, or is that bleeding coming at the wrong time? And of course, sometimes there can be an overlap. So with too much bleeding, heavy menstrual bleeding, remembering to be thinking about checking blood count and ferritin, that many women will be anemic, and that in itself then of course can have other impacts on day-to-day life. Things like fibroids are so common. About 1 in 3 women will have fibroids, and about 1 in 3 of those will be symptomatic from those fibroids. Too little bleeding, well, hormonal transition times like at puberty and menopause can be times where cycles will often be irregular and start getting really sort of unscheduled in terms of the bleeding. PCOS, again, extremely common. About 1 in 10 women will have PCOS, where ovulation is irregular and so cycles are irregular. But there's much more to PCOS than just periods, isn't there? It's something that can really affect the whole person. So again, a really key condition to think about diagnosing that presents with gynae symptoms potentially, but can have impacts on lots of other things. Bleeding that comes at the wrong time. There can be, again, lots of different reasons here. We need to be thinking about potentially more serious things, our cancers, infections, obviously, too, chlamydia and things particularly, as well as kind of local causes, and particularly genitourinary syndrome of the menopause, very, very painful bleeding that some people might be experiencing. And then pain. Again, there's often debate about whether periods should be painful, whether some degree of pain is expected. But again, come back to that question about impact on day-to-day life. If pain is stopping somebody attending school or college or work, stopping participation in fun things, in social activities, then that's not normal. And again, we know that endometriosis affects around 10% of women, so it's really common again. And on average, it still takes about 8 years to diagnose. It's tricky, isn't it? Because we can't easily diagnose it in primary care. We're meant to think about that gold standard laparoscopy, which can be tricky to access and not everybody wants to have. But I think for us, the key is considering it, thinking about it in our differential, remembering to ask about the menstrual cycle. If we're seeing somebody with GI symptoms, with diarrhea, with constipation, perhaps with abdominal pain, some of the less classical symptoms, we would tend to think about it. Hopefully, if somebody's coming with pelvic pain, but just thinking about asking about periods, asking about cycles, relationships of symptoms to cycles with lots of other presentations. And that can be really key to helping us make these diagnoses. The same's true with PMS and PMDD. Again, really common. So the prevalence of moderate to severe PMS is quoted as being up to 30%. And of severe PMS or PMDD, around 5 to 8%. So again, there's a lot of women out there who are having really, really difficult symptoms every single month. And of those with PMDD, more than 30% will have attempted to end their own life. So it can be incredibly impactful. And again, for us in primary care to make that diagnosis of PMDD, it's really key that we get used to asking about cycles and relationship of symptoms to cycles when we're seeing somebody with low mood or depression. Somebody with depression obviously can just have depression and be a woman who's also menstruating. They may have depression with a premenstrual exacerbation of their symptoms where things get a lot worse in that premenstrual week. Or they may have PMDD where actually those symptoms get a lot better as then the period comes and those hormonal symptoms change again. So the key is thinking about hormones, thinking about cycles, asking those questions. And the same as us, that if we haven't thought about it and haven't made those connections and haven't asked, we can't expect the people seeing us on our clinical practice to either. It's not common knowledge that hormones can affect lots of different conditions. Lots of people may have heard about PMDD now. There is more and more awareness, but the onus often is still down to us, isn't it, to be raising those different things in our own differential. And many of us weren't taught about these conditions. I certainly wasn't at med school. I don't remember doing any learning about PMDD, but hopefully the more awareness that we bring, the more we can really support people with these conditions that can really, really impact on day-to-day life. So we've talked about how common some of these conditions are. I think it can be really interesting to do some really quick little searches if you're in a general practice. Have a look, see how many people you've got coded as having PMDD, as having endometriosis. Often it's nowhere near the expected prevalence, which can help us just to recognise how many people might be out there struggling who we don't know about. So that can be quite an interesting one to think of. So I'm going to move on now to menstrual health. As I say, there's a webinar all about that where we spent an hour kind of talking through those things in lots more detail. So do have a peek at that one if that would be helpful. And do feel free to pop things in the chat as we go. So with contraception, one of the key things at the moment is the anti-hormone sentiment, isn't it, around contraception? It can be really tricky. We know that nationally, the rates of people who are choosing not to use any contraception at all are really increasing. It's a standard question that's asked at abortion clinics, and the numbers are going up and up. And there's also then this anti-hormone kind of sentiment where lots of people are really worried about using any hormonal contraception. Partly that's through some of the things that are out there on social media. again, we did a webinar looking at this last year, and I spent quite a bit of time looking on social media about what's out there, and it's frankly terrifying. All sorts of different stories shared again and again and again that can be really frightening for people. And I think it's really important we don't just dismiss that. We need to know what people are hearing. We're very good in primary care at thinking about ICE, ideas, concerns, and expectations. And at the moment, with hormones, this is really, really important because people might have heard all sorts of things and so be really put off. There are also some really good things out there that perhaps we need to be a bit better at signposting people towards, recognizing that social media is a really common source of information, particularly for younger people these days. You might have heard of The Lowdown. It's a really popular website. It's essentially a bit like TripAdvisor for women's health, where people give ratings and sort of give their feedback on all sorts of different things. It's not just contraception, it also covers other things, menopause and things too. But it's great because instead of people just hearing about the negative experiences around coils, for example, there's lots of people who are kind of writing reviews saying having a Mirena fitted has changed their life. It's been hugely positive for them. So it gives much more of a kind of balanced view. So that's a really useful one potentially that people can look at. And Talks with Dr. Sese too, again, is a really popular channel. She posts on TikTok and Instagram and places and has a YouTube channel. And again, she does really good information videos that are really popular, again, particularly with young people, where she'll just really look at lots of sort of hot topics within women's health and lots of different contraception things in particular. So they can be good ones potentially to link to from your practice website, perhaps. Yeah, just recognizing kind of that things have sort of moved, haven't they, in terms of how people get their information. AI is the next one that we're all going to have to think about, isn't it? And then in terms of choices, so as I'm sure most of us do, I can see we've got some real experts here in terms of people who are on the call, but remembering to offer all different methods. We know nationally LARC rates are unfortunately falling year by year. Locally, we do pretty well. But again, making no assumptions about what might suit that person in front of us the most and giving all the different options. I'm sure you've probably heard we've now got UNO locally, sort of combination of Unity and Brook. It's really worth having a look at their website. If you haven't had a look yet, there's lots of information on there. There's a professional section and lots of patient information as well. Links through to lots of really useful guidance for us. So it's a really useful source, one to use regularly. And then abortion. So, around 30% of women will have had an abortion by the age of 45. We know it's very common. So again, can be useful to think around in terms of that sort of patient navigation. Does your practice website share information about how somebody can self-refer if that's their preference? Do your care navigators in your practice know that that's an option as well? So again, that can be useful just to consider, recognizing that it can be really difficult for people to talk about, and so knowledge of that self-referral can be really helpful for them. I'm going to have a little think now about fertility. Really common consultation that people might be concerned that it's taking a while to conceive. And the stats say, of course, that most couples will conceive, but it can take a while. And certainly if you're trying to conceive and it's not happening, it can feel like everybody else is pregnant. You sort of see buggies and babies everywhere. And after spending lots of years using contraception, suddenly it doesn't happen. It can be really tricky. And about 1 in 7 couples will have some difficulty conceiving. And I think many of us will be quite confident in thinking around kind of the different factors that we should consider if we're having that consultation with somebody or with a couple. Asking about the menstrual cycle is really, really key. Thinking about lifestyle factors for both partners, smoking and alcohol particularly. remembering to think about the male partner, and thinking about bloods if indicated. But for me, what's really key is for us to know when we can refer people early. The criteria on this are on the form, linked through from our remedy guidelines. Some of them aren't that clear. Severe oligomenorrhea is down there. And so if you're seeing somebody who's only having a few periods each year, if their cycles are, say, every 60, 70 days plus, and they're menstruating on a really irregular basis and really infrequently, you don't have to wait, you can just refer them straight in. It doesn't specify what severe oligomenorrhea is, but every time I've referred somebody under that criteria, they've been accepted. So that's useful to know about. The next one is bilateral blocked fallopian tubes. So just routinely asking, has there been a history of severe PID? Have they perhaps had an ectopic and had one tube removed, and were they told at the time, oh, the other one looked a bit damaged, just for you to know. So again, thinking about whether there's a risk of that and asking and looking for a bit more detail if that's the case. People with stage 4 endometriosis can be seen early. They'll usually have been seen by gynae already, so hopefully they'll have been briefed about that. And then POI. Again, hopefully that's quite obvious, and when we think about it, it is. But again, not everybody with POI will necessarily be symptomatic. So by POI, we're meaning premature ovarian insufficiency, so early menopause before the age of 40. And somebody might have had bloods done quite a while ago, may not be that symptomatic, may not necessarily talk to you around that. But yes, another category where we can refer people in. And then another one is AMH. Now, this is a blood test that we don't typically do in primary care. It's not something that would be part of our standard practice, but it's quite common now in private practice and on people just doing self-tests, going along and just having bloods done. And if the AMH is under 1, again, this is a criteria where we can refer people early. And then there are some male criteria too. So again, particularly from the semen analysis. So a very low sperm count. So these are areas where it's really useful to kind of identify, so we're not sending people away unnecessarily. A question came through about previous PID. Is that enough to refer, or do we need radiological evidence of tubal disease? I think that's a really good question. I think if somebody has had really symptomatic PID, then we know the likelihood potentially of damage is quite high, particularly if they might have been symptomatic for a little while before treatment. I think if you have got somebody where you don't have evidence, I'd be tempted to refer anyway and explain the story and see what happens. I think apart from doing a referral that might get rejected and the time that takes, I think that would be what I would do personally. And if I'm seeing somebody about PID, particularly if they've been very symptomatic, I'll often try and just gently bring this up at the time. Now, it can be too much at a first appointment, but if I'm seeing them for a review appointment or speaking to them by phone, perhaps a little bit later to check as to how they've got on, I'll often sort of say, we know potentially this can be linked in terms of tubal damage, which can have an impact later down the line. So if in the future you're trying to conceive and it's not happening, please chat with me sooner rather than later. It's a difficult balance, isn't it? You don't want to really scare people and worry them unnecessarily, but equally you want people to be kind of forearmed to know that potentially it's something that could affect them later on. The last criteria in terms of the referring early is psychosexual. And one couple springs to mind that I saw quite some time ago, where the male had really, really difficult premature ejaculation and they weren't managing to have penetrative sex at all. But they came in saying, oh, we've been trying to conceive for nearly 2 years and it hasn't happened. And it was, thankfully, I kind of asked enough questions to kind of manage to elucidate that information, which was obviously quite key information, and led me to a sort of psychosexual referral. But again, if somebody has been seen by the psychosexual team and had support around that and still is unable to have penetrative sex, then we're able to again refer those couples earlier. Although it's likely that they'll have been waiting probably even longer by that stage. So a run through of some of those criteria, which I think can be helpful. Again, it comes back to these key principles, doesn't it, around knowledge of normal and abnormal and all of these different things. There's so much to be thinking around. We're going to skip across in our life stages now to menopause, jumping ahead for some people, or as I say, not for everybody, because menopause can happen under the age of 40. So there's been lots, hasn't there, since the Davina menopause revolution. There's lots more awareness of menopause and particularly of perimenopause. Some might say too much. But again, we know there is still quite a few women in their late 30s, early 40s particular, who might have symptoms that are perhaps less classical: sleep disturbance, palpitations, joint pain, anxiety, low mood, UTIs, recurrent thrush, where if we don't think, again, to ask about cycles, ask about hormones, we won't necessarily get to the bottom of what's causing those symptoms. So I know there is a lot more awareness, but there is still some people who are self-treating for thrush, all the time, are having multiple courses of antibiotics for UTIs, where those symptoms are hormonal in origin rather than necessarily recurrent thrush or recurrent UTIs. So again, coming back to that, just thinking, are these symptoms cyclical? Has there been a change in cycle that might be suggestive of perimenopause? Has their mum gone through menopause early? Are there autoimmune factors that could be linked with an earlier perimenopause? So just again, thinking hormones, thinking cycles, trying to kind of join the dots together with some of these presentations. Talked earlier about kind of prevalence and our practice prevalence versus perhaps what the expected prevalence is in the community. And with POI, premature ovarian insufficiency, traditionally we've thought about the prevalence, it's been quoted as around 1%, but we think actually it's probably closer to 3 to 4%, because as we've said, not everybody's symptomatic. Which is interesting, isn't it? When you know about the different symptoms that often come with perimenopause, you think, gosh, well, if it happens at 25, surely somebody would be really symptomatic, but not everybody will be. And we know, particularly in some communities, it can be more common. So some of the Afro-Caribbean communities. And if perhaps you've completed your family in your early 20s and then your periods stop in your late 20s and you're not symptomatic, you might not come forward. So you might not, have a consultation around it. And POI is a really significant risk factor for longer term health outcomes, particularly thinking about heart health, about dementia, about osteoporosis. So again, our routine questions around what's happening with your periods. Do these symptoms relate to your cycle? Sometimes are going to really, really help us in identifying POI. For most people, menopause, the average age will be 51, and the average length of menopause will be 4 to 8 years. So many people will be symptomatic in mid-40s. 1 in 20 will go into menopause by 45, and so will be symptomatic perhaps from their late 30s, which is still sort of far sooner than we might expect, I think, very often. And we know the impact for some can be really significant. So that can be impacting on physical health and mental health. It can be on relationships. The divorce rate for women is most common between 45 and 55. It can be on the workplace, particularly in organisations like the NHS, where more than 50% of us will be women over the age of 45. So the impacts can be significant. There can be this real ripple effect. I'm sure you've probably seen the updated remedy pages. There's loads of information there now. They're much more comprehensive. A lot of time and energy went into doing that, so I hope they're helpful. The British Menopause Society also have lots of resources from their website, and their patient-facing arm is the Women's Health Concern, which again produce lots of really good leaflets for women. And I think, again, it's an area where we can make such a positive impact for people. Again, I would really encourage you to think about those questions around impact on life, just like we were talking about with menstrual health. What's the impact of these symptoms on them? That will help you really understand what it is you need to try and support them with. So impact on life, and then also just try and, if you can, in that very limited time, think about asking proactively about libido and about genitourinary symptoms, because we know those are ones where even if we're having a lovely consultation and we're talking about all sorts of things, very often people won't bring these things up themselves. And it's down to us as the clinicians to be quite proactive and just ask. And, what about vulval and vaginal symptoms? What about your bladder? What about sex? Just trying to enable people to talk about that if they want to. Because again, things like our local estrogens can make such a difference. We've got some now like Gina and Ovest that are even available over the counter to women over the age of 50. So that's really helpful for some people. Pelvic health. So this is another huge area potentially. Again, we've got a couple of webinars from the Training Hub with a women's health physio that are worth a look if you haven't seen those. But this is another area where there is a huge impact on people's lives. It's not spoken about much. People see it as being embarrassing and feel a lot of shame. It's very hidden. It's also really normalized, isn't it? That because we know it's so common, particularly after childbirth, people assume to expect it. And we've even got brands like Sweaty Betty who now make leggings with built-in pads, so that if you leak when you exercise, that you're covered. So again, this is an area where we need to be quite proactive in talking with people, because often patients will have just normalized it. I've had 2 kids, so of course I'm going to leak. But again, the stats are really quite frightening. So there's said to be more than 14 million adults experiencing regular urinary incontinence, so more than 30% of the adult population in the UK, and 6.5 million experiencing fecal incontinence, so around 15%. About twice as many women as men are affected due to anatomy and pregnancy and childbirth and menopause. Yeah, the stats are extraordinary. And then we know a significant proportion of women will also experience a degree of prolapse. So around 40% of women over the age of 40. And that can be made quite a bit worse, as can any of these symptoms, by menopause. So sometimes people will have had some stress incontinence, but at a level that they're kind of managing with, that's not impacting too much. And then menopause comes along, and those tissues around the genitourinary tract, which are very estrogen dependent, suddenly really start to struggle. And this can make a slightly tricky situation suddenly become really, really difficult. So it can be a time again where these symptoms can have much more of an impact again on life. Coming back to our key questions. What's happening with the cycle? Oh yes, my periods have stopped now. What's the impact? Actually, it's huge. I want to go to the gym and I can't. I want to have sex and I'm too worried that I'm going to leak. So for some people, it can be really, really impactful. And it's an area we need to ask about to understand what people might be going through. And it's an area, again, we can make a really big difference with. Again, think about putting the pelvic health self-referral link on your practice website. We know people find it difficult to talk about. Put some information on there, normalizing that it can be difficult, but also normalizing that there are things that we can do, that we don't have to put up with this. that local estrogen, that non-hormonal treatments like vaginal moisturizers can be really helpful with soreness. There are devices like Contrail, a little device that people can use themselves that can be really helpful with urinary incontinence. People can buy over the counter. Pessaries can make a really big difference with prolapse. So again, asking and then taking it seriously and really supporting people to get the help that they need so that these symptoms aren't impacting significantly on life. And as I say, all the links for these things are in the sheet that we'll email around. Do feel free to pop any questions or thoughts again in the chat. I've left lots of time to be able to talk about things, so do feel free to pop things in there as we go, or we can come to those at the end. Female cancers. So this is a picture from the Eve Appeal charity, which is a sort of awareness campaign really to kind of help people know that it's not just cervical cancer, not just ovarian cancer. They're by far the most commonly known about, aren't they? Many of us, I think, will be much less confident about recognising vulval cancer. Certainly patients are very likely to be unconfident. Many people are not confident in knowing where their vulva is, let alone knowing if there's been a change in the appearance. So again, we need to start with our own awareness, our own knowledge base. We need to know what questions to ask, how to support people in asking the right questions so they can give us the right answers. And we might need to talk to people about what their bodies look like, about their anatomy, about how to self-examine. We need to remember to offer and encourage examinations for really common symptoms if those symptoms don't improve. So, obviously we see lots and lots of people with itching, with soreness, with pain during sex, and we might empirically treat for thrush, with estrogen for menopause, but we need to safety net that if things don't improve, we need to have a look, because on occasion it will be a vulval cancer and not recurrent thrush or lichen sclerosis or the genitourinary syndrome of the menopause. So that examination sometimes is really key, isn't it? So often we feel much more familiar with cervical cancer, with breast cancer. We're more aware, patients are more aware because of the screening programs, because of just general awareness in the media. But one area, particularly for women with breast cancer, can be around menopause after breast cancer. And again, I just wanted to highlight a relatively new organisation to you called Menopause and Cancer. It's headed up by a lady called Danny, who went through breast cancer quite early. And it's a really amazing resource to support people post-cancer around menopause. There's a book, there's lots of webinars, there's kind of lots of patient information, and they do quite a bit of CPD for professionals as well. And so they're a really great organisation, really useful to have a look at their website. Because, cancer affects people in lots of different ways, doesn't it? But particularly kind of gynae cancers and breast cancers can have quite a unique impact on menopause particularly. So that could be something else that you might take forward from today to think, right, I'm going to have a look at that and see what's out there, because that can be really helpful for your consultations. And then lastly, I was just going to think about some of the long-term conditions. So often when we think about women's health, we think about menopause and contraception and periods. We don't necessarily think about cardiology and about osteoporosis. But of course, there's so much more to women's health than periods and menopause. So just thinking about osteoporosis initially, so we know about 50% of women will have a fracture after their menopause. It's extremely common. And women have an 11% lifetime risk of fracture of their spine against 2% in men. And, some of these fractures will be really minor ones, won't they? It'll be a wrist. Some will be really significant, the hip fractures, with that really substantial mortality rate and impact on independence, particularly in later life. So again, for those women with POI, for those women with an early menopause, thinking about maximising their bone health is a really key consideration. Trying to get our teenagers and young people exercising while in their teens, 20s, because bone mass peaks in our 30s, and so really trying to get that peak to be as high as it can. Thinking about nutrition, about encouraging people to be moving, to be strength training if possible, to be laying down and that muscle mass and supporting their bone mass. We talked about cardiology in a previous session. It was a great webinar if you haven't seen it, with a GP with a special interest in cardiology. Menopause is again quite a key transition time metabolically, where we see the cardiovascular risk really increase. Cardiology is an area where there's a really clear gender health gap between women and men. We know that for women under 55 with a heart attack, the mortality is about 2 to 3 times that of men, because our awareness of how heart disease presents in women and our treatments have been geared and designed around presentation in the male body. Neurodiversity is a huge area, isn't it? And again, particularly at menopause, we're seeing many people really recognise their own neurodiversity, often for the first time, when it's sort of unmasked, if you like, by those hormonal fluctuations. Often, when you chat with them, you can kind of see a similar pattern at puberty, at other times of hormonal transition, and sometimes during the menstrual cycle as well. We know those with ADHD have much higher rates of PMDD, for example. So there are some real kind of common links. Estrogen affects dopamine. There is a very real relationship between ADHD worsening at menopause. But of course, it can be tricky because menopause itself can lead to that sense of overwhelm, to cognitive difficulties. And there's again lots written about with ADHD, where sometimes people then are reading around it and thinking, oh, this must be me, because that's what my experience is at the moment. So as ever, it's complicated, but certainly we know there are many, many women out there who are certainly neurodiverse who don't have a formal diagnosis. Again, we haven't known about it, have we? Going back certainly to when I was at med school back in the 90s, I don't ever remember thinking about ADHD or autism in adults, let alone in women. But yes, another area where we're all having to do more learning, do more sort of understanding in terms of what people's experience might be. Migraine, again, I think is a really interesting one with hormones. Often it starts at menarche, often it will come with menstruation. We'll see it in the pill-free week on combined pill as the estrogen levels are lower. It tends to be better in pregnancy, worse postpartum, worse at perimenopause, and then better postmenopausally. So there's this definite relationship with estrogen. So again, if you're seeing somebody with migraine, just getting them to think beyond triggers of cheese and chocolate through to thinking about the relationship of their symptoms with their cycle can really help them with understanding what's happening, and can help you with supporting them then with management too. And with depression, we mentioned earlier that depression, there can be a premenstrual exacerbation, as there can with many, many different conditions. Overall, about twice as many women will experience depression compared to men. And we also see this kind of triad, these hormonal transition times. So we see, unfortunately, a link with postnatal depression, with PMDD, and with depression at menopause. So often if somebody is someone who's experienced PMDD, then has had postnatal depression, they're somebody who we know is more likely to experience troubles with their mood at menopause, which can help you again in terms of of supporting that person to understand their experience. So a very rapid run through a sort of women's life course with a few key sort of features that we've spoken about. And really, I think the key message is being to just ask and think about hormones, to ask and think about the menstrual cycle, thinking about the impact of those symptoms on somebody. And yeah, really interested if there's any questions or if anybody's got any comments or thoughts. I'd love to hear from you if you want to pop it in the chat, or if you want to unmute and have a real life chat, please do. And if not, I will let you go and enjoy the rest of your day and have a little bit more time. Hopefully you can grab some lunch. But thanks for being here. I can't see anything coming through on the chat. So thanks for coming. I hope that was useful. Hope it got you thinking a little bit, and do feel free to have a look at some of the other webinars, and we'll get that sheet sent round with some links that you could look at. Enjoy the rest of your day.